So, good afternoon, everyone, and a warm welcome to our Policy Modeling for Health Lunchtime webinar series. I'm Dr. Nora So, the Program Manager for Policy Modeling for Health based within Public Health at the University of Glasgow. Policy Modeling for Health is funded by UK Research and Innovation as part of its £35 million Population Health Improvement Network. This supports innovative research aimed at tackling the wider determinants of health and reducing inequalities. Our work is based on developing advanced computational models to help policymakers explore the likely effects of different policy choices on health outcomes across society. This webinar series offers insight into our activities presented by members of the research team. Each talk is designed for a general audience, but with opportunities for you to ask questions, and recordings of all our events are available on our website. So now I'm delighted to introduce our speakers for today. Dr. Rebeka Balogh and Dr. Sarah Amele, both University of Glasgow researchers in our causal estimations work package at Policy Modelling for Health. Growing wealth inequalities mean that an increasing number of people in Great Britain lack any type of financial buffer, yet the health consequences of wealth poverty remains poorly understood. Rebeka and Sarah will present evidence from the Longitudinal Wealth and Assets Survey showing how living with minimal or no monetary reserves can directly shape health and well-being. Please feel free to submit questions anytime via the Q&A tab, and we'll come to these at the end of the presentation. So over to you now, Rebeka.
Thank you, Nora, and thank you everyone for joining us this afternoon. In the next 20 minutes or so, Sarah and I will be discussing a piece of research that we've done as part of the project. So Sarah and I have worked within a work strand that deals with causal estimation. And the idea is that our work then feeds into microsimulation to see how changes in certain economic determinants of health would affect population health and health inequalities. If we could go to the next slide, please. And the next one as well. So because we will be discussing wealth, my colleagues thought that it's best to illustrate it with a bathtub analogy, so I need to give credit to them. So if you think of income as a sort of water coming through the tap, and whatever is accumulates in the bathtub is wealth. So wealth is essentially a stock of assets and debts. If there is no or little water, so income coming through the tap, then whatever is left in the bathtub is something that individuals and families can draw on in terms of income shocks. There has been research done to say that wealth and health are strongly associated, but there's very little causal evidence. And why causal evidence is important in this matter is if we want to establish how a change in wealth would affect a change in health outcomes. And if there is, and if there's multiple factors at play, then this is difficult to establish. So there may be kind of common causes of the two. So let's say that individuals experience unemployment at the start of the career, and this negatively impacted both their wealth and their health. And this is a phenomenon that we call confounding. And when there's confounding present and unaccounted for, then we have difficulties deriving these causal estimates. We could also imagine that ill health also affects wealth. So there is kind of arrows going both ways in a reverse causation is happening. So again, we need to really carefully think about these mechanisms, these dynamics at play, and we also need an appropriate study design that can account for these. If we go to the next slide, please, Sarah. So wealth is something that's becoming more and more of interest, both from a policy and a research point of view. And this is largely because there are large and often increasing wealth inequalities. I just took one statistics to highlight the sort of scale of it. Sorry, if we were to rank all families in the UK from those with the least amount of wealth to the most amount of wealth, then those at the bottom 10%, so those in the lowest wealth decile, on average actually have negative wealth, and that is that they have more debts than assets. Whereas those in the top 10%, so those with the most amount of wealth, have on average £1.5 million per adult. Historically, there's been a larger evidence base for income and health than has been for wealth and health. And that is mostly because it is quite difficult to measure and to capture wealth. In surveys, you have to have loads of questions to get an accurate picture of wealth in all its dimensions. Some countries have or have had a comprehensive wealth taxation, and those might have registered data that may be available to use and could be linked to data on health. There's been studies done in Norway and Sweden with such a registered data. In the UK, we do not have such registered data available. Although there's, as I said, traditionally been more epidemiological evidence on income, there is starting to be more and more studies around wealth and health as well. A lot of them are associational, as I said, and not necessarily looking at a causal health impact. And if we go to the next slide, please, Sarah. And like I said with the bathtub analogy, the idea and why wealth may be so important for population health is that it may act as a buffer in times of economic shock. But what is kind of less known around health outcomes is what is actually insufficient wealth. So what might be a particular threshold below which kind of the lack of wealth may be particularly harmful for health. And that is where the concept of wealth poverty comes in. It's also referred to as asset poverty or net wealth poverty. And it's less universally known than, let's say, relative income poverty, and there's no universal single definition. But it's been defined often in relation to the income poverty line. So let's say having wealth below 3 months equivalent of the income poverty line. And that essentially means that if there's no other income coming in, then individuals or households can draw on their assets already available and remain above the poverty line for, let's say, 3 months. And there's been one US study done that linked wealth poverty different similarly to an increased probability of poorer health, but this was not a causal study, as I said. And so we wanted to estimate the causal effects of wealth poverty in Great Britain on health and wellbeing outcomes. And now I'll give over to Sarah, who will talk about what we did and what we found in terms of methods and results.
Hi, thank you, Rebecca. That was a great introduction. So yeah, I'm Sarah, and I'm just going to be talking you through the methods and the results. So for this analysis, as Rebecca mentioned, we were using data from the Wealth and Asset Survey. So this is a longitudinal study that's conducted by the Office for National Statistics across Great Britain every 2 years. And we use data from waves 5 to 7 of the survey. And this was collected between 2014 and 2020. Our sample included all adults aged 25 and over who are living in private households and responded to at least 2 consecutive survey waves. And to address attrition bias, we applied the survey weights that were provided by the study. So we looked at So we looked at 6 different outcomes, and they were split into 2 categories. So the first is self-rated health. So we measured this as, we included this as a binary outcome and as a continuous outcome. So for the binary measure, we looked at very bad versus bad scores versus fair, good, and very good. And we also included it in its continuous form from 1 to 5. Secondly, we looked at well-being measures, and these were all measured on a scale of 1 to 10. And so the types of well-being we looked at were life satisfaction, happiness, so how happy the individual felt yesterday. We looked at worthwhile, so that was the extent to which the individual feels their activities are worthwhile. And finally, we looked at anxiety, and that was how anxious they felt yesterday. And the anxiety scale was reversed, so that higher scores indicated better well-being in line with the other well-being measures. So we looked at 2 exposures. So we had gross financial wealth poverty and net financial wealth poverty, which was just the same as the gross financial poverty, but we deducted any debt or liabilities. Both were measured at the wave prior to the outcome and were split into 3 categories. So we had no poverty, mild poverty, and severe poverty. Mild poverty was defined as a household with equivalized wealth below 3 times the monthly income poverty line. So this is around £4,000. And severe poverty was defined as a household below the 1 month, with wealth below the 1 month income poverty line. So this is around £1,300. So essentially trying to capture households that living paycheck to paycheck. So to estimate causal effects accurately, we adjusted for potential confounders. So we had 2 time invariant confounders, gender and educational attainment. And we also had time varying confounders. So we included employment status, marital status, survey date, household income, geographical region, number of dependent children, and age. Sorry, this is just a little bit more detail on how we defined our exposure. So these were both defined by the ONS, so they used them as like test statistics in some of their analysis. So we took their definition of gross financial wealth, which is gross financial wealth minus any value held in children's trust funds. And again, net financial wealth is just the same, but deducting total value of financial liabilities. So this is a directed acyclic graph, or a DAG. So for those of you who are not familiar with these, this is just a way to illustrate the assumed relationship between our exposure, our outcome, and our confounders. And DAGs are important in causal analysis because they help us to identify the appropriate set of variables to adjust for in order to estimate the causal effects. And so by mapping the possible pathways through which variables influence one another, DAGs help us to avoid common sources of bias, such as unaddressed confounding or adjusting for inappropriate variables. And this DAG was based on previous literature and guided the analytical approach that we used and that I will describe next. So to estimate causal effects, we use marginal structural models. And these are particularly useful in this context because they account for exposure-induced time-varying confounding. And this is where, in this analysis, so this is where prior wealth influences confounders, which then in turn affect future wealth and health. And this type of confounding can't be appropriately addressed using standard regression techniques, which is why we used marginal structural models. And so the method involves firstly estimating stabilized inverse probability weights. And this allows us to create a pseudo population where the exposure is independent of confounders. And then any extreme weights, so these are weights that were at the highest and lowest 1%. Those extreme weights were truncated to improve stability, and then we combined the truncated stabilized weights with the survey weights, and these are then used in the model. So in the model, we also included interactions between wealth, poverty, and age, as well as wealth, poverty, and employment status. And we also adjusted for lagged measures of self-rated health, poverty status, and the corresponding well-being measure. So moving on to the results. So our analytical sample included 18,764 individuals, which contributed to just over 29,000 observations. Firstly, looking at gross financial wealth poverty, you can see that around 71% of individuals were not in poverty, 10% experienced mild poverty, and 18.5% experienced severe poverty. And when we account for debt, so the net financial wealth poverty variable, we can see that the proportion of individuals in severe poverty increased to 26%. And for the self-rated health and well-being outcomes, scores were worse among individuals in mild and severe poverty. Too fast. Okay, so this forest plot shows the causal estimates for our binary self-rated health outcome. So estimates for gross financial poverty are shown in blue, and estimates for net financial poverty are in orange. And so from this forest plot, we can see that for both measures, individuals in severe wealth poverty had a higher risk of reporting poor self-rated health compared to those not in poverty. So for gross wealth poverty, severe poverty was associated with a 34% higher risk of poor health, and for net wealth poverty, the increased risk was around 26%. So this slide, apologies, it's quite busy, but it has the results for our continuous self-rated health outcome and our 4 well-being outcomes. And here the significant effects we only observed significant effects for net financial wealth poverty, specifically for severe net wealth poverty. And we can see that severe net wealth poverty was associated with worse anxiety and poorer happiness scores. Again, this is compared to those not in poverty. And I think, yeah, that's me. I'm going to hand back to Rebeka.
Thank you, Sarah. So I will just summarize our main findings and what these findings might mean. Again, severe wealth poverty, both when we just considered assets and also when we considered assets and debts combined, was linked to a higher risk of poor self-rated health with a 34 and 26% increased risk respectively. And when we accounted for that, so net financial wealth, severe wealth poverty also had a negative impact on anxiety and happiness for the well-being measures that we looked at. Again, this was severe wealth poverty, so taking 1 month equivalent of the income poverty line. So our findings may mean that mental well-being may be more sensitive to indebtedness. There are also probably distinct mechanisms at play for the 2 measures that we considered. Some limitations that should be borne in mind when interpreting these findings. So again, we didn't have register data available, we used survey data, and although it was quite detailed and complete, we still only had a few waves available that we were able to use. So hopefully future research will look at this again with a longer follow-up. We also had no information on ethnicity in the data set that we used, and also we only looked at a few health outcomes. So hopefully again, future research will consider a wider range of health outcomes in relation to wealth poverty. So comparisons to other studies are difficult because there is little evidence when it comes to wealth poverty and not a lot of causal evidence around wealth and health in general. Again, our focus was financial wealth. So we didn't consider other aspects of wealth, such as property wealth or physical assets, or even private pension wealth, even though wealth is inherently multidimensional. And the reason for that was partly because we wanted to focus on assets that are more liquid, that are more readily available for individuals to draw on in times of need. And also, this is more of a technical issue, but in causal infinite, there's also a criterion that should be satisfied, and that is that the causal effects of interest should be defined analogous to a hypothetical policy intervention. And so changes to wealth poverty is a bit more complicated to define if we consider multiple dimensions of wealth, Again, happy to answer questions if there are any on this. And ultimately, what our results suggest, and there is a potential population health gain to be made from reducing severe wealth poverty. And there's a few key references that I put on the next slide in case there is of interest to anyone. And also I wanted to thank and acknowledge our funders. Policy Modelling for Health is part of Population Health Improvement UK and funded by UKRI. As Nora was saying at the beginning, we're very happy to take and answer questions.
Thank you both for that excellent insight into what wealth poverty means for health and well-being. As Rebecca's just said, we now have an opportunity for some questions. So if you have not already submitted your questions, please use the Zoom Q&A tab at the bottom of your screen, and we will get to as many as time allows. So first question, what types of wealth or debt were included in this analysis? Oh, did we lose Sarah?
We might have done, but I'm happy to answer until she's back. So I think I said it this at the end, in the end, but we looked at financial assets and liabilities, so we didn't consider pension wealth, physical wealth, or property wealth, even though those are again available in the data set and often included in analysis due to the fact that they are liquid forms. And there's a full list. So Wealth and Assets Survey has really good good documentation. So that will include all the different kind of assets and debts that encompasses.
Thanks, Rebecca. The second question was what future research around wealth and health might be needed?
Well, I'll answer that again until Sarah comes back. So I think there's a few things that should be investigated. So looking at other dimensions, aspects of wealth is one. Also, would be good to know how the trajectories of wealth and trajectories of debt, so how individuals accumulate or don't accumulate wealth and how that impacts health in the long run is another one I think that is definitely would be of importance to investigate.
Thanks, Rebecca. Someone noted that in the inclusion criteria, you said age 25 plus. Is there a reason why you excluded individuals under 25?
So the main reason for that was that we focused on individuals in their core working years. So particularly because we included employment status as a confounder, as a factor that could vary and likely influences both wealth and health. And so just because of that, so that individuals are not inactive due to studies as much. And I think Sarah's back as well. I can see that now.
I'm so sorry. I don't know what just happened. My laptop just
It's
gave up
fine.
on.
Welcome back, Sarah.
Thank you.
So we've got another question. Have you found a way to flag up findings with relevant policymakers?
Do you want to answer that, Sarah?
Yeah, I was gonna throw that one to you. Sorry, could you repeat the question? What was it?
Have you found a way to flag up findings with relevant policymakers?
Yeah, I mean, I think the good thing about our research group is we work quite closely with policymakers, but yeah, Rebecca might be better positioned to answer that and give a bit more detail about how we do that.
I was gonna say the same, that we because inherently policy is sort of a core of what the project is about. So I think that is the next step really, to see what are the sort of potential policy changes that could impact wealth poverty and yeah, what the kind of wider implications would be.
Thanks, both. And Sarah, I might just come back to you on one of the questions, which is what future research around health and wealth might be needed. So if you could add your sort of your thoughts on that, that
Oh,
would be
sure.
great.
Sorry, I missed Rebecca's answer, but I think so. We're planning to look at different measures of wealth, and that's kind of our next project. Using different and exploring different ways to measure wealth and looking at different types of wealth. So obviously this was focused primarily on financial wealth. And so I'm sure Rebeka went into detail about what types of measures we included. But obviously we excluded a lot of types of, we excluded housing wealth and pensions and those types of things. So yeah, we'd be very interested to see how those types of wealth impact health.
Thanks so much, Sarah. I think we've hit kind of the half an hour mark, so we might conclude the session today. So that concludes our Q&A, and thank you for joining us for today's webinar and for all of your questions. A full recording will be available on the Policy Modeling for Health website next week, so please do share it with colleagues who were unable to join us today. Our next lunchtime webinar will be on the Thursday, 21st of May, titled SIMPATS, a dynamic micro simulation model for life courses. Details will be sent with this event recording. So thanks again to Rebeka and Sarah and to you all for joining us. Thanks very much. Bye.